when talking to your radiation oncology colleagues, their modern radiation techniques are incredible, really good, and really do quite well with pain relief as well. But one of the things that when we kind of compare the strategies that we use is XRT comes with it a risk of potential skeletal adverse events down the line. So basically pathologic fracture down the line. So that's why I really like this complementary approach of RFA and kyphoplasty first. And then your rad-onc is protected, your patient is protected from that happening, basically.
Yeah.
And as you said, it can be, I personally haven't had the experience, but I've heard from many people who have trying to do an RFA or even just a standard kyphoplasty in irradiated bone, even a couple of weeks after. It's like trying to drill into concrete, and it's terrible.
It is no fun.
And it's tricky because modern systems of care are so complex and multifaceted. And in a perfect world, I think that would be the great and the correct order of operations, but doesn't always go that way. And so I'm wondering if this is your experience too, if you can get them in after radiotherapy, but before it's been too long, you usually still have a good shot at having a non-aggravating RFA.
Yes, that is true. I still think that we do the patient the most amount of good by treating them, kyphoplastying them, and then having the radiation therapist go to town, or radiation oncologist go to town and do whatever they're going to do. Mostly because, as you say, this is the best shot you're going to have at it, and you want to give yourself the best opportunity to be successful. If you're going to do it, make it as easy as you possibly can. Why make it hard for yourself?
And for the patient, for that matter.
Yeah.
If I've experienced anything, the patients do not typically like it. And our patients are usually under moderate sedation. When you really start to have to give them the wham on that mallet, it's not usually taken well.
No, nobody enjoys that part. I don't enjoy it. The nurses don't enjoy it. The patient doesn't enjoy it. Nobody enjoys the feeling of, if I'm breaking a sweat, pounding that in, then everybody in the room is uncomfortable.
Have you used any of the power drill methods?
Yes, once. It was one of these patients who I attempted to do a kyphoplasty on, or an RFA and kyphoplasty. She had a painful T5 metastatic lesion. And
it's a tricky one.
It was a tricky one. So I brought her in to do a RFA and kyphoplasty, and bam, 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 nothing. So we had to send her out and bring her back, and I had to go down to the operating room and get a striker drill.
Okay, the real big boy toy.
And drill into this vertebral body so I could do the RFA.
Awesome. And sometimes you have to. And one thing, the reason I bring this up is I was just doing a bone marrow biopsy the other day, and we had a rep in who was kind of showing me just all the different pieces of the kit. And Dana Dunleavy has also talked about some ways he's kind of used multimodal, if you will, parts from the bone marrow biopsy, hand drill, and bringing that over, and you can get access with that much easier in this type of bone, K-wire, and then take that out and exchange that for your standard cannula. That's one way of doing it as well, without having to get the big time drill.
And that's exactly what I did with the striker. I got my drill in. I was able to drill down. Then I put in a K-wire and exchanged it for the cannula for the RFA device.
Yeah, I bet you wish you had done that from the beginning in that case.
I do. I wish I had done that from the very start.